Cast is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you so much for joining us today. My name is Tamara Bingham Noyes. I'm the Director of Business Development here at Center for Change. We're so happy to spend an hour with you today and appreciative of you taking the time. I want to go through just a couple of things quickly before we get going on the webinar so that you have an idea about what's going to happen as we move forward. Everyone is more than welcome to submit questions in the questions pane that's located in the toolbar. And we'll try and see if we can get to a couple of questions at the end. So feel free to submit your questions via a written question in the toolbar, and then we'll keep an eye on those and pick some to answer at the end. A copy of the post test is in the handouts pane in the toolbar. Feel free to view or print the test questions for review during the webinar. However, keep in mind that the test must be taken online in order to receive continuing education credit. Also in that same handouts pane in the toolbar is a copy of the PowerPoint slides. So you're welcome to download those so that you can look at them later, etc., if you would like to. At the end of the presentation, the webinar program will pop up and ask you to fill out an evaluation of the webinar. If you'll take just 30 seconds or so to complete that evaluation, that would be really helpful for us. It's a continuing education requirement that we gather feedback, and it's anonymous. So if you'd please do that for us, that would be great. And then about an hour after the presentation ends, you'll get a separate follow-up email from GoToWebinar with instructions regarding taking the post test and receiving a certificate of attendance. Again, you must take the test online and pass in order to get credit for continuing education credit, and that certificate will automatically be downloaded. Once you pass the test, it automatically downloads to your computer. So let's go ahead and get started. I'm going to turn the time over to Taralyn. I will give a little FYI that she is, bless her heart, is here with laryngitis and had no voice at all 2 days prior to today. Has a little bit of a voice today, so we're going to have her sit close to the mic. Hopefully you can hear her all right. And we're just thrilled that she's able to do this for us after all. So I'm going to turn the mic over to Taralyn. She'll introduce herself and then launch right into the webinar.
Thank you so much. And I am sorry for the laryngitis, but this is a topic that I am very passionate about. I've been working in eating disorders for about 4 years as a nurse practitioner. And when I first started working in eating disorders, I was so sad because I thought I was going to have to give up another really wonderful thing that I used to do, which was pain management. I was in pain management for years and thought that I would not be able to do that anymore, but it did not take long before I found out that I was still working in pain management for sure. So let's go ahead and get started with Hidden in Plain Sight. Let's talk about common pain complaints in anorexia and bulimia. I do work at Center for Change, so you will hear that in throughout the slides. So what are our objectives today? What are we trying to accomplish? Well, when we're all done, I hope that you will be able to identify different causes and presentations of pain in patients who suffer from eating disorders, specifically anorexia and bulimia. We'll talk about a validated screening tool that can be used to screen patients for both anorexia and bulimia. And we'll also talk about how to connect eating disorder patients to an effective outpatient interdisciplinary treatment team. These patients are very much in need of holistic care. We'll also hope that you are able to recognize important findings that necessitate a higher level of care than what they are currently getting. So let's go ahead and talk about our first case study. I love case studies because they illustrate things so well, and I can talk about a bunch of my patients all at once represented by one person. So I've named this one Mary. Mary is a 24-year-old female, just delightful, but she has debilitating migraines. She's had them for 7 years. She complains that they last more than a day. She gets them about 3 times a week. So this is very problematic for her in her life. The severity sometimes changes with the seasons. It is a little bit hard to pin down, but she's coming to you as her primary care provider to get help with these migraines. Now, if you're not a primary care provider, I hope that this will still be useful to you because you will see this in your patients. These migraines have been so bad that she's had difficulty with her college courses. She's having to take days off frequently from her job because of these migraines. And she complains of pretty typical migraine symptoms. She's sensitive to light and sound. The pain is usually unilateral. She doesn't have an aura, but not everybody with a migraine does. She's presenting like a typical migraine patient. So why would her care provider even begin to think that she has a migraine? Well, let's keep looking at Mary. She does complain of occasional dizziness, and she's tried many medications over the last 7 years. Now remember, she's only 24. She's been dealing with this since she was a teenager. She's tried the triptans, sumatriptan, rizatriptan, without too much improvement. She's used lots of different NSAIDs, mostly ibuprofen, Excedrin, Aleve, without a lot of significant benefit. Tylenol doesn't seem to touch it. But a year ago, she did start topiramate, or Topamax, and since then, it's been a little bit better. She also will use coffee or diet colas to tame that headache down a little bit. Caffeine can be useful for headaches. And today, when she sees the care provider, she is asking that they increase her topiramate. She also is interested in Botox and other treatments, but mostly she's interested in increasing the topiramate because that's the only thing that's helped with her migraines so far. So she goes through a usual exam. They check her vital signs. Her heart rate's normal. Her blood pressure's low, but she's a young, healthy female. It's okay to have a low blood pressure. Her temp and O2 are fine. But in looking at her BMI, you can see that it's just a little bit lower than it should be. So if we use the 18.5 to 24.9 range, she is just barely below that, you can see. They do an exam, her heart, lungs, and bowel all sound fine. Her neuro exam is totally normal. And they do go ahead and draw some labs at that time. They check her potassium. Now her potassium is low. It's at 3.2. That is something that will red flag any healthcare provider. It makes us really nervous when we see a low potassium. We really like our potassium to stay within a normal range. Now, if you're not a primary care provider or other medical person, you will maybe not know that lab values will be different. Lab to lab, they calibrate their equipment differently. So what you're really looking at when you look at labs are the normal range per that lab. So you can see that she's 0.3 below normal, which is actually quite a big difference for potassium. Her complete blood count is also showing that she's mildly anemic, and she's got some low platelets. So her care provider might start to think that maybe she's got a little bit of pancytopenia, but not sure at this point. So let's look at why patients with anorexia and bulimia complain of headaches, or what kind of headaches they get. Headaches are a really common complaint among my patient population. At the Center for Change, our inpatient and residential patients, of all of those, 43% of them complain of very significant headaches, whether those are migraines or other type of headaches, whether they're daily or infrequent but severe. 43% is a lot. So what are the causes? Well, before they come into us at the center, what they might show up at an outpatient clinic showing up with is dehydration. Dehydration, I would say, is the number one cause of my patients' headaches. They get dehydrated from restricting with anorexia, from laxative abuse, diuretics, from vomiting. If they're purging in any way, it really trashes on their fluid volume, and they can get pretty significant headaches from that. We do see a lot of migraines. A pain from TMJ, that jaw pain can really manifest itself as some pretty significant headaches. We also have a lot of patients who have headaches from anxiety. There's a really strong mind-body connection with anxiety. As many of you will already know, it will manifest itself as chronic neck pain, headaches. We also have a significant patient population that gets headaches because of low glucose. That will certainly do it if they're fasting, if they're dieting. A lot of our patients are at risk for falls. We'll talk more about that later, but we do see many patients who have already had concussions because they have been dizzy with their eating disorder behaviors and have fallen and hurt themselves. Now, I put this next one in parentheses because it's not something I've seen in any of the literature as far as pain goes, but we know that patients who decrease their weight, especially rapidly, have significant shrinkage of their brain. The myelin sheaths that surround all nerve cells are made of lipids, and when people are burning through their protein and their lipids, which they do with rapid weight loss, they will actually have shrinkage of the brain. So I don't think that can be comfortable, so that's why I put that in there also. So during treatment, we like to tell people that their physical complaints are probably going to get worse before they get better. They'll go through caffeine withdrawal. We have a lot of patients who abuse caffeine. I once had a patient who told me she had 96 ounces a day of black coffee And that's pretty much what she had all day. So it was very difficult, even with appropriate management, for her to go through that first few days. It was rough. So caffeine withdrawal can cause some really serious headaches. The metabolic changes that go along with receiving treatment certainly can cause headaches. I do see a lot of tension headaches. Going through treatment is very stressful. People will have a lot more tension, at least for the first little while. And so I do see more tension headaches at the beginning of their stay. They will often be having medication changes, and the psychiatric medications very commonly will have side effects such as headaches, especially in the first few weeks that they're changed. Now, their TMJ can likely get worse, because if they were restricting before they came in and now they're eating again, they're using their jaw more than they had been. So that can certainly make their headaches worse. And especially at the beginning of their stay, they're still at risk for concussions. We do a lot of walker and wheelchair and elevator fall precautions because we are really trying hard to avoid falls in our patients. So that's something that we're still very concerned about until they have cardiovascular stability. Now, if they had migraines before, those migraines may get better or worse during treatment, depending on what was triggering those migraines. If it was stress or tension, it certainly can get worse before it gets better. Refeeding syndrome can cause headaches. We aren't going to go into refeeding syndrome a lot, but we'll mention it here and there. So I'll talk more about that later. And anxiety. Anxiety can cause headaches. It just can. And there's a lot of stress that goes in to treatment, but it's very worth it. So let's come back to Mary. Now, Mary had a very savvy care provider who asked about her relationship with food. And Mary, of course, being the good eating disorder patient that she was, completely denied any problems. She said, yep, I drink well, I eat well, I don't have any problems. And because of her potassium, however, she continued to get care and workup. And at the third visit, Mary decides that she can trust her care provider. And after repeated questions about her relationship with food, she then reported that she had a 7.5-year history of restricting both food and fluids. Now remember, she's been suffering from migraines for 7 years. Does that ring any bells for anyone here? I see a lot of this. So she also is able, after further non-judgmental questioning, to report a 3-year history of purging. She's vomiting up to 7 times a day. And she's got a 1-year history of laxative abuse, so even worse with the fluids, right? She's taking 7 to 15 doses of a stimulant laxative every day. 3 days a week she's doing that. So right away, she gets referred to a therapist and a dietitian, and the determination is made that she needs to step up to residential care. She does so. She spends 2 months in residential treatment, and lo and behold, within those first 2 weeks, her headaches have decreased by more than 75%. So what was triggering those migraine-like headaches? Well, it was the fluid restriction. She had been so low on fluids that she had been triggering these awful headaches with dehydration. So during that stay, her topiramate is tapered off. It's come to the attention of the providers there at the center that she had been abusing it for appetite suppression. People look online. They know what the side effects of medications are, and they look for things that will help with appetite suppression. And so she had not been wanting that topiramate for the right reason, and she no longer needs it anyway because her headaches are so much better. So it is tapered off and discontinued. Now, while she's in treatment, she gets a DEXA scan. A DEXA scan is a bone density scan that we will do for all our patients, whether it's when they step down out of residential care or during, depending on the circumstances. And her DEXA scan shows osteopenia. So even though she is only 24 years old, she has the bones of a 60 or 70-year-old. Now, osteopenia and osteoporosis are problems that do not go away rapidly. Now, she's 24. We say, peak bone density is about 20 years old. And after about 30 years old, you lose your ability to lay down new bone tissue. So she has some chance of gaining it back and getting rid of her osteopenia, but it's going to take monitoring and watchfulness, and especially avoidance of eating disorder behaviors, which has caused the osteopenia to begin with. So let's move on to a different case study. We've talked about headaches. Let's talk about somebody with a different kind of pain. Linda is a 36-year-old female. She comes to her clinic, to her primary care provider, with a complaint of chronic chest pain. Usually it's on the left, sometimes it's central. Now, Linda is a very successful, high-power woman. She's an attorney. She's a very pleasant person. She takes time to coach cross country. She really wants to help youth. And this is what she tells her care provider about her chest pain. It's been sharp, it comes and goes, and it's been going on for 18 months. Now, this is kind of a hallmark of patients that I take care of. They are not in a huge hurry to get their medical problems taken care of. Often they're tough, or they just don't want to go in because they're afraid somebody will ask them about possible eating disorder behaviors. So all different reasons, but she hasn't had a lot of care. She did see a cardiologist 8 months ago. We'll get to that. She reports that her chest pain is worse with activity, but she still feels it at rest sometimes. So it's a pretty significant thing. The more activity she does, the more she feels the chest pain. Occasionally she gets short of breath with it, but not always. And the cardiology workup that she had, she tells you was negative 8 months ago, except for some little bradycardia. Well, on further questioning, it wasn't a little bit of bradycardia. She had a pacemaker placed. I have had a handful of patients who have had pacemakers placed because of their bradycardia, and their cardiologist never knew that they had an eating disorder. So she had her pacemaker placed because her heart rate was sometimes in the 30s. But she tells you, I'm not really worried about my bradycardia because all my family members have low heart rates and I'm super active. I think it's just because I am so healthy. This is something I hear regularly from my patients with bradycardia. It's definitely because of my family history. So you do a workup, or the practitioner does a workup on Linda. The vital signs show that, yes, she has a little bit of bradycardia, but it's not very significant. She's just down 2 points from where she should be, from the low level of 60. Her blood pressure is a low normal. Her temp's fine. Her BMI is normal. So why on earth would her care provider think to address questions of anorexia and bulimia? This is something that happens a lot in the clinics. It's under people's radar because they think that you have to be way below normal BMI to actually have a problem with an eating disorder, which of course is a fallacy. Her exam is pretty normal. Her lungs and bowels sound normal. But when the provider listens to her heart for a while, they hear a little systolic murmur, which kind of clues them in that something really is going on. Her heart sounds are a little distant. Now, when you ask her about it, she says, oh no, they said my heart sounded normal at my cardiologist 8 months ago, but you can tell that it's not as loud as it should be. So that's another clue that something is really going on here. And then her neuro exam is normal. So her provider does an EKG there in the office. The heart rate is a little bit lower, which is what I usually see. The EKG heart rate's usually a little bit lower than the resting one in the office, the quick check. Her QTC, which for those of you who are not clinical, is a measure of the amount of time it takes for the electrical impulse to travel from one point to another in the heart. We like to see the QTC at 430 or below. Actually, below 430 we consider normal. At a cardiologist's office, they may not even blink at a QTC of 448 because they see so much worse. But in a healthy adult female, we should be seeing a QTC of less than 430. So her provider is clued in that her QTC is too long. But other than that, she has a normal sinus rhythm and the EKG is normal. So why do patients with anorexia and bulimia show up with chest pain? We see it in 31% of our patients. I got those numbers by having our medical records department look back through all of our inpatient and residential patients for the last 3 years. And it showed up on 31% of our patients that they were reporting chest pain. So why do they have chest pain? Well, pre-treatment causes. Let's look at those. The number one greatest is atrophy of the heart muscle. When patients lose weight quickly, when anyone loses weight quickly, they're going to burn up their muscle tissue. And the heart is a big muscle, a very hardworking, wonderful muscle. And if you are losing skeletal muscle everywhere else, you are also losing muscle in your heart. And that is not a comfortable thing. It can lead to heart failure. We see because of that atrophied muscle that the structure holding up the mitral valve, which is the left AV valve, the valve between the atrium and the ventricle, that it sort of collapses a little bit, that the structure doesn't hold up the valve properly. And so there's some mitral valve prolapse, which can also be painful. Not always, but can be painful. Patients with anorexia and bulimia can have arrhythmias, which may or may not be painful. And I see an awful lot of costochondritis, which is an inflammation of the cartilage between the sternum and the ribs. And it's one of those inflammatory conditions of opportunity. When you're feeling run down, when you're sick, when your body's not doing so great, or when you're really stressed, that's when costochondritis is going to set in. It's not dangerous, but it can be very uncomfortable. My patients have described to me anything between, a little annoyance here and there, to feeling like they were going to have a heart attack. And we actually have sent patients to the emergency room because of heart attack symptoms, and everything checked out fine, and it was costochondritis. So you see a lot of variability with that one. Pericardial effusions are also another cause of chest pain in our eating disorder patients. There's wasting. There's a few reasons for the effusions, or water buildup around the heart. Wasting of the left ventricle. Sometimes it's an inflammatory thing. It can possibly be related to a hypothyroid condition, but we don't usually know why they get the pericardial effusions patient to patient, but we can assume that it's because of their eating disorder and the wasting of their heart muscle. Now, the pericardial effusions can be mild and not cause much problem, or they can be very dangerous. So if there's any concern for that, we'll be sending patients off to cardiology to make sure that those are getting better. Occasionally, they will need pericardial centesis when you actually draw the fluid off of the heart, but often it can just be watched or managed with medications. Now, anxiety can also cause a lot of chest pain. Often with anxiety, patients will have a tightness bilaterally in their chest, but not always. Sometimes it can be left-sided, so it can be really hard to sort that out. It can be heartburn. I have also, just like costochondritis, heartburn can be anywhere from a mild annoyance to feeling like you are going to die from a heart attack. And I see a lot of patients with esophagitis, esophageal ulcers, varices, and tears, which can be very dangerous and quite painful. So during treatment, like I said, things can often get worse before they get better. Weight restoration tends to bring on chest pain in some patients. Heart failure, obviously, if the mitral valve prolapse was there before, if the heart failure was there before, if their atrophied heart muscle was there before, it's going to take a while for all that to resolve. Weight restoration is one of the big markers of improvement, but it can persist a little bit past that. They can still have arrhythmias until they're stable. The costochondritis can still be a thing. Like I said, it's very stressful to go through treatment. They do a lot of hard work when they are working through their eating disorders and the anxiety and depression and other problems that they come in with. Now, the pericardial effusions, like I said, they take a while to resolve, so we'll probably see them while they're in treatment. Anxiety may get worse or better depending on how they're doing. Heartburn, if they had not been eating before and now they are, their heartburn may be much worse for a while. So we treat that pretty aggressively. And the same goes for the esophagitis and the ulcers. Now, the tears, we take very seriously. If they have any blood in their purge, they're going to probably have endoscopy. So we keep an eye on that for certain. Now let's go back, to our patient. So luckily, her provider believed in using the SCOFF questionnaire. You can go ahead and read that while I take a drink. So the SCOFF questionnaire has been around for a while. And it asks a few questions, and you can read through those. Now remember that the SCOFF questionnaire is a screening tool. It is not a diagnostic tool. If you read through those yet, you might see those in your near future. A score of 2 or more indicates that the patient may have anorexia or bulimia and that it needs to be worked up. So let's come back to Linda. She answered yes to number 3. She's lost 25 pounds in the last 2 months. That is very rapid. And she also said yes to number 4. She feels like she's fat even though other people say definitely not. So that prompted some more questions and some further assessment. And the patient reported that this was the first time, remember she's in her 30s and has had chest pain for 18 months. Excuse me. This is the first time she's ever been asked about these behaviors. But eventually, she reports running for more than 2 hours a day, a 20-year history of restricting. Remember that this is the first time she's ever been asked about eating disorder behaviors. This, to me, is very tragic. She has an echo done because of what the provider heard on exam, and they did find some pericardial effusions, mitral valve prolapse, so that's why the murmur was there. And unfortunately, her insurance does not cover behavioral health hospitalization because she certainly needs it. But they will cover IOP. So she's very closely followed by her primary care provider, her psychiatrist, her dietitian, and her therapist, because they have to watch her very carefully for refeeding syndrome. Because of her fast weight loss, she is definitely at risk. So they monitor her very closely. Excuse me. So what happens with Linda? Well, through treatment, she starts to weight restore. She gains 19 pounds over 2 months. Her QTC, remember that EKG number we were talking about, has now come back to a very normal number, almost 50 points below what it was before. And by month 3, her chest pain has resolved completely. So it was all from her eating disorder. And interestingly, her heart rates are now completely normal also. So her heart rates, obviously, now that she's weight restored and we can say, weight restoration process is done, this is what her actual normal resting heart rate is. This is what she's supposed to be at. So everything she said about being so healthy and her family history of bradycardia was nowhere near accurate. So her DEXA scan shows osteopenia in both the spine and hips. Because she's past 30, this is not going away. There are some medications that can turn osteopenia around or osteoporosis around, but they're mostly approved for postmenopausal women. So she'll probably need to follow up with an endocrinologist to monitor that over time. So chest pain is certainly a problem with patients with eating disorders. So let's move on to our third case study, Chloe. Now, Chloe is a 30-year-old nurse. I knew that eating disorder patients were often very bright and successful people, but that is something that has really, within the first week of working in eating disorders, it was very clear to me that these are sharp, brilliant people. These men and women that struggle with eating disorders, they, it can be really intense for them, and they are amazing people and can totally turn their lives around if they can get their eating disorder taken care of. So what does Chloe report? Well, she's been having sharp upper abdominal pain for 6 months, half a year she's been dealing with that. But she's had reflux problems, since she was a teenager. For 15 years she struggled with reflux. It doesn't get better with Zantac. Those H2 blockers don't do much at all. She often feels fullness, bloating, distension. It can be really painful. It can inhibit her ability to function for sure. And it seems to be getting worse, not better. She does have intermittent problems with constipation, but she can't attribute any of her symptoms because when she doesn't have constipation, or when she does have constipation, those symptoms don't change. So she reports pain after eating. Now that pain after eating isn't so bad after breakfast, but boy, by dinner time, that fullness and bloating is so significant she can barely do anything. She doesn't really get much improvement with Miralax and Gas-X. And her exam is totally normal. Her labs are normal. Her exam is normal. Her vital signs are stable. And this is unfortunately what you will normally see with most eating disorder patients because it takes a long time sometimes for them to show up anything on their labs or vital signs. So it's really easy. That's why these eating disorders are such great pretenders. They pretend to be other things because it's not obvious to a care provider that that's what they're dealing with, which is why screening is so important. Okay, so why do people with anorexia and bulimia have abdominal pain? There are so many causes, and I did not even put a percent of patients who report abdominal pain because I think it's probably 98+% of my patients report abdominal pain sometime during their stay. So why do they get abdominal pain? Well, pre-treatment or post-treatment, they can have gastroparesis, which is a slowing down of the muscle of the stomach. So when the stomach is not given input, when they're not eating or whether they're purging it all out too soon, nothing's getting the stomach is not having stimulus to contract. The stomach is a really muscular organ, and that muscle just stops working over time. The innervation to it says, oh, well, never mind, I guess you don't need us. And when you start to eat again, the stomach fills up, but the mushing and the contraction of the stomach doesn't happen. And so the food just sits there, and it can be nauseating, and you get fullness and distension and pain, and it gets worse in the evening, and it's just awful for a lot of people. I also see a lot of patients with constipation. Remember how much we have problems with dehydration related to fluid restriction or purging. Constipation really is an outcome of that. Pancreatitis, if you're not eating ever, your pancreas doesn't like it. And pancreas pain is not like any other pain. It is excruciating. Cholecystitis can also be extremely painful, pain after eating, because that gallbladder is extremely unhappy. It can be caused by eating disorders. IBS, I see it along a lot of my patients, whether it's a cause of the eating disorder or whether it's an outcome. I think it goes both ways. Gastritis, the lining of the stomach can be really irritated by these behaviors. And patients who chronically use laxatives, who abuse laxatives, will have diarrhea, which is also extremely uncomfortable. They may have developed food intolerances. And then SMA, the superior mesenteric artery syndrome, when that artery gets compressed, oh boy, that can be agonizing, and it's more noted after meals, and it can actually be quite dangerous if it's not caught. I also have a lot of patients with urinary tract infections. These UTIs come about usually because of the dehydration, but also patients with anorexia do not heal well. They don't fight infection well. Their immune system is usually quite lowered. So UTIs are definitely a common occurrence among my eating disorder patients. Now, ischemic bowel is not a common occurrence, but it is a possibility. I've only seen it a few times in the last 4 years, but I have had patients who have used stimulant laxatives so much that their bowel has become ischemic, has stopped working, and part of it has died and had to be removed. So I don't like to talk about it a lot with my patients because it is rare, but it is something that kind of lurks in the back of my mind. Now, during treatment, remember, everything gets worse before it gets better. That gastroparesis was not being challenged very much when the patient was engaging in restrictive behavior or frequent purging. However, now they are having meals and snacks all through the day, and so that gastroparesis can be quite severe and very distressing. Same problem, the constipation can get worse. Their gut has not been used to processing, and their bowels just are sluggish often. Now, the fluid resuscitation happens over the course of a few days. That sort of constipation will go away, but the other is pretty predominant, so predominant that we put almost all patients on a 7-day course of Miralax, which is a non-stimulant osmotic laxative, which will not hurt their gut over time, but is very effective. Now, the pancreatitis can certainly get worse because it will be worse after eating, and now they're actually getting nutrition in. The IBS can certainly get worse also because not only during treatment are they getting nutrition, they're also getting a variety of foods that maybe they had been avoiding. The gastritis can certainly get worse. The food intolerances, we tend to try not to honor those too much. It is really important for people to challenge their food intolerances, but that is something that can bring about some discomfort. And the SMA, like we talked about before, can be life-threatening, so we're on our watch for that. Gas pain, because of those sluggish bowels, can be pretty significant. I have heard male care providers kind of poo-poo gas pain like, oh, it's no big deal, it's just gas pain. Well, if you've had surgery before or been pregnant before, you might know that gas pain can actually be excruciating. It can be extremely uncomfortable. So patients, they come in to treatment, they expect to be getting better, but because of their eating disorder behaviors, especially if they've been severe, they may be up against a pretty significant struggle with abdominal discomfort. So we are pretty aggressive about trying to help them with their constipation, with their gastroparesis. Will often involve GIs. We'll send them out for consults if we're worried about what might be going on the inside. If we're worried about the esophagus, if we're worried about the lining of the stomach, if we're concerned that their constipation is getting severe, we'll send them out for an x-ray. We take this pretty seriously because even though it's caused by the eating disorder, it's really important, I think, for patients' pain to be treated and well controlled if they're going to get better. It's really hard to focus on therapy and be doing really difficult work emotionally when your body is in significant pain. So let's keep going. So Chloe's care provider, the first time they saw her, remember she's complaining of this abdominal pain, and they treated her with a stronger antacid. They gave her a PPI, a proton pump inhibitor, like omeprazole or Protonix. And then she came back for her second visit. She said, well, it's improved a little bit, but I'm having some throat pain. Now, throat pain can be an indication that they're having reflux that's kind of silent, that's hidden, and that they're not necessarily feeling it in their chest, but they're still having it. So because of the throat pain, the provider then looks in the mouth. So because of that, some significant further conversations happen, because once the care provider looked inside Chloe's mouth, they saw that her molars had kind of moderate perimyelitis, meaning that the enamel of the biting surfaces of the molars and the backs of the incisors had significantly deteriorated. I have seen this anywhere from a little bit of mild discoloration on those molars. I've seen it to severe cavities. I've seen it all the way to, meth mouth. It can be so awful what the purging does to the teeth and to the mouth. She also, today, not the last time the patient came in, but today, the provider notices that there's mild swelling of the parotid glands, which are kind of in the back of the face on both sides. And they will swell up for a few days after severe purging episodes. So the teeth and the parotids are now giving a lot more clues. But I have to say that very often these patients will present with no symptoms at all that suggest specifically an eating disorder. That's why screening is absolutely imperative. So the provider asks some non-judgmental questions about if the patient's had any weight changes lately. And after they've talked about that, the provider then asked about some possible history of purging. And it can be really hard to talk about purging with patients because they don't want to admit it. It's often something that they want to hide. It's not something that even those close to them even know about sometimes. I've had patients who hid it from their spouse for years. So it's really, really important with all patients, but especially with eating disorder patients, to be very non-judgmental, to normalize that other people are going through the same thing, that you've had patients who've had significant weight changes because of purging behavior or other things, dieting, and to not show a flicker of judgment about that, because if you do, they will not be sharing any information with you at all, and you will not be able to help them. So Chloe was then able to report a 33-pound weight loss in the last 2 months, which is severe weight loss. That is very concerning. After further conversation, and this was not a fast conversation, it took a while to get this information out of this patient, she reported that she'd been purging for 9 years. It'd been worse in the last 4 months. In the last 4 months, if she ever purged if she ever had more than 200 calories at a time, she would just go ahead and purge that right away as soon as she could. And that happened about 4 times a day with many purges per episode. So no wonder her teeth are deteriorating. But, at first glance, remember that when Chloe came in, everything looked normal. Everything looked normal, except this pain that she's been having. So further questions. Chloe reports that in the last week, she noticed some blood in her purge, which is really the reason she came back in, because, she didn't really think you'd be able to help her all that much, but she got kind of scared when she saw that blood. And so when the care provider finds out about the blood, they very appropriately sent her to the emergency room where they did urgent labs and a further workup. So her potassium was 2.8. I used to think that potassium of 2.8 was incompatible with life. It often is, but I have had a few patients with purging behavior who have been that low, and it is scary. It is dangerous. That is death at any moment. I do not feel good when I see potassiums that low. Like we talked about, the levels can depend on the lab, but anytime you see that it's lower, anytime you've got a low potassium, that is a big red flag. Also, you can see low sodium in patients who purge through laxative abuse. You can see other electrolytes go haywire, but in this case, it was Chloe's potassium that really clued them in that she was in trouble. Now, her electrolytes got stabilized in the ER. They gave her fluids, they gave her potassium, and they gave it to her all very quickly. And so now she's got edema. Now, you take a patient with an eating disorder who has lost 30 pounds in the last 2 months and you give them significant edema, guess what they want to do as soon as they leave that emergency room? Yeah, they want to go immediately start engaging in eating disorder behaviors because their body dysmorphia has just hit the ceiling and they are in pretty big trouble. Now, patients who have been very dehydrated, who now get fluid resuscitation, especially if it's done quickly, are at risk for Bartter syndrome. Now, we get really excited about this because if they're swelling up because of their hyperaldosteronism, not letting them pee out any of their fluids, then they are also at risk for fluid in the lungs. And I don't want my patients to drown. So we watch this pretty closely. While they're in the center, we monitor them, and very often we'll treat with diuretics, spironolactone if needed. Not everybody needs it, but some do. And it is something that has to be watched very carefully because it can be dangerous. Her endoscopy, which was also done relatively quickly, showed Mallory-Weiss tears, and that is why she is bleeding. She has active bleeds in her esophagus because of her severe purging behavior. Now, okay, a little bit of blood, who cares, right? I see a little bit of blood all the time, and I don't even bat an eye. No big deal. But blood in the esophagus or anywhere else internal that you can't put pressure on gets to be dangerous very quickly if a hemorrhage takes place, because unless you are very close to an emergency department and a surgical center, you might not make it. So we get very serious about these tears. She also has esophageal varices, so basically varicose veins of the esophagus, and severe esophagitis. This reflux that she's been dealing with for 15 years has not been nice to her at all. So they do a gastric emptying study at the same time, and they see that she has severe gastroparesis. Nothing moves from her stomach to her gut. It just sits there, and that is so uncomfortable. And that's why she's having the pain after eating. So because of her very difficult and complex picture, she is urgently connected to a therapist and dietitian and very quickly admitted to an inpatient treatment program to get stabilized. While she's there, her Bartter syndrome is managed, the edema resolves, and that's relatively quick, that the edema gets under control. Now, maybe it doesn't go away. It can take a few weeks for that hyperaldosteronism from the dehydration to go away, but with treatment, it can resolve pretty quickly and they can feel better. The gastroparesis, on the other hand, resolves very slowly. And like we talked about, it can certainly get worse during treatment because they are challenging the stomach so much more when they are getting nutrition. So the gastroparesis is something that slowly improves over time with avoidance of eating disorder behaviors. And when I say slowly, I mean slowly, months, years. It can take a long time if it's severe for that to go away. The reflux, on the other hand, for Chloe got better pretty quickly when she stopped purging, because that esophagitis was able to tame right down. Her proton pump inhibitors worked a little bit better when she wasn't challenging that quite so much. And her Mallory-Weiss tears did heal. She had a repeat endoscopy a month later, and they found that they had completely resolved. So Chloe's symptoms have been going on for a really long time. So her DEXA scan, her bone density scan, was not awesome. Now, osteopenia and osteoporosis, I have seen them both in teenagers, people in their 20s. It is very concerning. So she's diagnosed with osteoporosis, and she's referred to endocrinology for long-term management. This is usually something that really surprises patients when they're educated on it. When they started eating disorder behaviors, they did not sign up to trash on their heart and to demineralize their bones. Excuse me. So education is extremely important, not to try to scare them, but to really help them understand what is going on with their body. Now, Chloe very much needed regular follow-up with a GI. And I wish I could say that every patient is cured the first time they come in for serious treatment. You know, when they come in for inpatient or residential stays, some of them turn right around. They do really well through treatment and they never have to deal with their eating disorder again. But a lot of them will need repeat follow-up care. Many will need lifetime care because when people get stressed out, old things tend to resurface. So they may need off and on outpatient care all their life. They may need follow-up again in an inpatient or a residential facility. Everybody follows a different trajectory, but the good news is that with continued treatment, as long as they keep fighting it, it can resolve, it can go away. So here we have anorexia as the most deadly mental illness with a very high mortality rate, 10 to 20%, but it's curable. So the important thing is for them to get care, and especially to get care early. And if care providers are screening for eating disorders, not just thinking about it when somebody's BMI is 15, then we're much more likely to catch this early and treat it early and give them a life free of debilitating eating disorder. So we talked about headaches and abdominal pain and chest pain because they're really common ones that I see, and I feel like they really show what happens to the body during an eating disorder with eating disorder behaviors. But that's just the short list. And this list that you're seeing now, I would say is still not a comprehensive list, but this is what I see the most. Excuse me. So the emotional, psychological, and spiritual pain cannot be ignored. It can be very significant and very distressing, and it can cause physical pain as well. So let's talk about some of those. A lot of patients with eating disorders have comorbid anxiety and depression. So those certainly have to be addressed. We may find that those anxiety and depression resolves with treatment of their eating disorder. It may not. They may need continued care. Body dysmorphia certainly causes a lot of spiritual pain. And because eating disorders are so isolating, they really take people away from their close relationships. You see a lot of relationship difficulties, whether that's with a significant other, family members, parents, you name it. It can be really hard on the entire family, the whole social structure for this patient. They also tend to have decreased productivity when you have chronic migraines and chest pain and you can barely function because of your abdominal pain. Now, probably not all of those, but most of my eating disorder patients have at least one of those. It's going to decrease your productivity. And while in treatment, patients go through a lot of trauma work. Many of them do. So that is very painful for them as well. Musculoskeletal pain certainly is an issue. We talked about these patients who have osteopenia, osteoporosis. They're at risk for fractures. I have a lot of patients with stress fractures in the spine. That can be extremely painful. I have a lot of patients with chronic joint pain or muscle pain, muscle weakness from the atrophy of their muscles from these eating disorder behaviors. And they do tend to have more inflammatory complaints than the average population. Neuropathic pain is really hard to chase. It can be very tricky. My patients who have recently lost a lot of weight show up with a variety of paresthesias, often numbness, tingling in the hands and feet, but other nerve pain in other places that are unpredictable as well. Allodynia, pain where you should not be experiencing pain, is also something that comes up pretty frequently in my patients. They'll tell me that their skin just hurts everywhere and they don't know why, and it's so painful they can barely stand to put on clothes. That is from the demyelination of the nerves like we talked about. Those nerves are in trouble with significant fast weight loss or with a low BMI. It doesn't have to be fast weight loss. Hyperalgesia, feeling more pain than they should for the given stimulus, goes along with that as well. And I've had a lot of patients with strange neuropathic pain in unpredictable locations, and it may be related to inflammation, pressing on a nerve. It may be related to a joint deterioration. But what it comes down to is it's caused by the eating disorder itself, and fixing their pain absolutely depends on taking care of weight restoration and resolving the eating disorder behaviors. So that SCOFF questionnaire that we looked at can be a really useful tool. But like I said, it is a screening tool, not diagnostic. However, it is a very good screening tool when patients are honest. And sometimes patients do not want to tell anyone about their eating disorder. It is really common for them not to bring it up or to deny problems with it when they're asked, which is why it's important to use screening tools regularly. I have had patients who worked closely with a cardiologist or a GI for 2+ years. And I say, well, do they know about your eating disorder? And they tell me, no. And I ask them, well, why not? And they say, well, they never asked. Or they tell me, I was too embarrassed. I didn't want to tell them. He wasn't somebody I felt like I could talk to, or she wasn't somebody I felt like I could talk to. So as practitioners get better at interacting with patients and taking the time to ask these harder questions, we get better at catching things like this. I think the most tragic situations I've ever come across have been my patients who've been 50 or 60 years old and receiving treatment for their eating disorder for the first time. And it's been affecting them all their life and crippling them all their lives. And no one's ever asked them about it before. So it is extremely important to be working on screenings. The SCOFF is easy. You can give it as a written questionnaire with admit paperwork. It can be something they fill out while they're waiting to come back to the office. Or it can be an easy, I like to talk about a set of questions to help me screen for different kinds of problems. So can you tell me, have you ever had anyone tell you that you're thin when you feel like you're fat? Or have you recently lost very much weight? Those are easy questions to ask. They don't necessarily take a long time, but if they're not asked, you may never know that your patient has an eating disorder because they will not necessarily volunteer that information. So open-ended questions are extremely important. With pediatrics, we're really good about asking, tell me about eating, drinking, pooping, peeing. And we ask those questions over and over and over. But with adults, we don't ask those questions as frequently. Tell me what your diet is like. Tell me how often you eat. Tell me if you've been dieting lately. We don't ask those questions like we should. And then asking about their exercise and if it feels compulsive to them, if they feel like they have to exercise even when they're tired. And then very bluntly asking about eating disorder behaviors. Have you ever engaged in purging behavior? I know lots of people who look to that as a form of weight loss, or have you been dieting even despite significant weight loss? Those questions are extremely important and often overlooked. So avoiding judgment, obviously, they're not going to tell you a dang thing if it seems like you're judging them. So why is an interdisciplinary treatment team so important? Well, we just talked about how the eating disorder affects their whole body. It affects their whole life. They need a holistic treatment team. One member of this team is not going to be able to well manage an eating disorder. So the psychiatrist is often the lead, a therapist and dietitian, absolutely vital. The primary care or the lead specialist may be heavily involved as well. And those specialists can be broad and varied, GI, cardiology, neurology, just depending on what kinds of things their eating disorder has caused problems in their body, what kinds of problems they've faced. Sports med might be the first guess that something is really going wrong. Nephrology might be involved. I do see a lot of hits on the kidney, a lot of abnormal BUN and creatinine from the dehydration and from other eating disorder behaviors. So you may need to have a specialist heavily involved on your outpatient team as well. But it doesn't matter what everybody's doing if they don't communicate with each other. Communication between treatment team members is absolutely vital. And that's how you know usually whether it's time to step up or step down or change treatment is through communicating with each other. So that is something that I hope you will get out of this as well. Now, indications for a higher level of care can be really important. Basically, if they're in danger, they need to step up to a higher level of care. If their bradycardia is significant, if their QTC is high, if their heart is doing anything it shouldn't, if their blood pressure is really low. Like we talked about, the low potassium sodium can be very dangerous. If they're trying to do weight restoration at home, phosphorus and magnesium can be dangerous very quickly. Refeeding syndrome causes the phosphorus to flood into the cells instead of the bloodstream. But the cells need it, but the bloodstream needs it even more. You don't want to have cardiovascular collapse because of a low phosphorus. If they're having metabolic acidosis or alkalosis, that's why it's really important to be following lab values in these patients. If they're hypoglycemic, and if they're not weight restoring at the current level of care, whatever that level is, it means that they need more support than what they're currently getting. If they're losing weight, and like we talked about, if they're at risk for refeeding syndrome because of recent weight loss or because of a low BMI or because of very low intake over the last couple of weeks. Those are all really important reasons to step up to a higher level of care. Obviously, if they're having worsening behaviors despite treatment, something needs to change. If they're low BMI, if they have a low BMI to begin with, it can indicate that they're at risk for refeeding syndrome and really need to be in a facility where labs are being monitored regularly. And if they have medical complications, if they're not safe where they're at, those are all reasons to go to a higher level of care than what you're currently at. So I love a couple of really good references I'd like to point out to you. At the bottom of this page, you'll see Mailer and Anderson's work. It is a book. Eating Disorders, A Guide to Medical Care and Complications is really helpful. It goes through a lot of the psychiatric treatment. It goes through some of the therapeutic interventions that are needed, and it goes a lot through the labs and the physical manifestations and such. And you can see there are other references that you can scroll through if you'd like to get more information. Dr. Mailer is a really good resource, and also Dr. Gaudiani, that second one on the first page of references. I would definitely refer you to any of her works as well. So I think that we have a few minutes for questions if anybody has any.
We do. We have a couple. The first one, what are your clinical red flags for SMA? I had to ask what that was. Superior mesenteric artery syndrome. You
Yes.
probably knew, but I did not.
Yeah.
So
Okay.
if you repeat the question
Yeah.
and then answer it, that'd be great.
So what are the clinical red flags for SMA or superior mesenteric artery syndrome? That is a very good question. It's not something I see often, but on the inpatient side of the Center for Change, it's something we're watching for more frequently. So patients who have a low BMI are at risk for SMA, which is compression of that artery. And when patients eat and the stomach gets full, it compresses that artery. So you'll see a lot of post-meal pain with that. Upper abdominal, typically upper abdominal post-meal pain. So anytime that you're seeing that in a patient who has a low BMI, it is a definite red flag for SMA. Like I said, it's not common, but it can be dangerous. Obviously, we don't want to compress arteries. That's not a good thing. So that does require typically a feeding tube to decrease the pressure on the artery. And then once their weight has improved, once their BMI has improved, they'll no longer need that and they'll be able to take orally again.
Great. The next question, how do you help anorexic patients manage severe GI pain during refeeding while they phase off of opioids they have been using previously to manage the pain?
Oh, that is a really, really good question. I'm going to have you repeat that as I go back up to our abdominal pain slide.
Yes.
Okay, so tell me if I got this right. How do I help my patients with their abdominal pain during refeeding or during weight restoration or during treatment when they previously had been using opioids?
Correct.
Now, opioids are a horrible way to manage chronic pain, first and foremost. We will not use them. We'll taper them off quickly, or we'll have them taper off before they come in if it's safe to do so. And so obviously we're not going to be using those medications, and those medications are contributing to the problem because they cause such constipation. And constipation will make all your other pain worse, and it's very painful in and of itself. So it is important to get rid of the opioids as quickly as possible to begin with. Now, how do we manage abdominal pain in patients who come in for treatment? Well, it depends on what the abdominal pain is caused by. And that can be a little bit tricky to narrow down. So sometimes we'll have to be attacking it from a few different angles to begin with. Now, gastroparesis is the first one on the list. What do we do for our patients who have severe gastroparesis? Well, it can be really hard for them to eat large meals. So normally we give small meals frequently anyway. We do breakfast snack, lunch snack, evening dinner snack, right? So that's the first step on the list. Second step is to get rid of super high fiber things. We tend to, in our patients with gastroparesis, we'll pull off raw vegetables, raw fruit peels, things that naturally don't disintegrate well in liquid, things that will be hard for the stomach to pass through. And for some patients, that's enough. For other patients, we need to use medication. So we'll use erythromycin, sometimes azithromycin, if insurance won't cover the erythromycin because it is expensive, as a gastric motility agent, which can be quite helpful in some patients. The other medication that we use sparingly, but it is generally somewhat effective, is Reglan or metoclopramide. Reglan increases gastric motility. However, it's quite sedating, and it comes with some very unpleasant side effects if you use it long term. So we try to use Reglan sparingly and for the shortest duration possible. Now, if it's constipation that's causing their pain, which if they've been on opioids is probably part of the problem, we are pretty aggressive at treating that. I'll have patients on Miralax from every other day to 6 times a day, whatever it takes. And we'll sometimes go to other medications like Linzess or Amitiza if the Miralax is not doing it. I like to stick with Miralax because it is so easy to titrate. And typically the constipation gets better over time, and you're not going to need those medications long term, especially once they're done with weight restoration. The constipation and the gastroparesis tend to not be quite so problematic, not because the gastroparesis goes away, but because it's not being challenged so much once they're down to a maintenance meal plan. So the gastroparesis they may continue to struggle with, but once they're done with their increases, their decreases, and they're to a maintenance meal plan, if they needed weight restoration, their gastroparesis will significantly bump down in pain. Now, pancreatitis, we will probably be involving a GI specialist for pancreatitis. We do, actually, when we see that. Cholecystitis, we refer them to the surgeon if necessary. IBS, we treat with IBS medications. We may use, do I have a lot of other questions? Because I could talk about this forever.
You do,
We'll
but
use
we're
IBS
gonna have time for
medications.
one more.
Okay, and then we pull off all stimulant laxatives. So the chronic diarrhea should not be a problem, but occasionally I'll have problems with diarrhea patients. We talked about the SMA. We treat their UTIs and encourage the fluids. And then if they were to have ischemic bowel, obviously that would necessitate a surgical consult.
One more question we have time for. Do you generally recommend that patients with a history of purging get an endoscopy?
No, not necessarily. If they have not had problems with blood in their purge and they are not having significant upper GI pain, then they don't necessarily need endoscopy. So it really depends on their history, on what they've been seeing, what they've been experiencing, and it can be different for a lot of different patients. I'm trying to think of a number, but I know at least a few times a month I'm referring to GI for a possible endoscopy. So we do it, but it's not something we do for everybody.
Cool. You want to just wrap it up, and then I'll come on over?
So I hope that was helpful. I'm very happy to answer further questions. I don't know if you can see my email address already.
I don't know if they can. So if you'll say it, that'd be great.
Yeah. So my name you'll see on the first slide is Taralyn Johnson. So my email address is taralyn.johnson@uhs.inc.
Nope. UHSINC.com.
At UHSINC.com. There we go. Thank you.
You're
very
welcome.
much.
Thank you, Taralyn. And she may have been hard to hear there at the very end, so I'll say her email address again. So it's Taralyn Johnson, so that's TaralynJohnson@UHSINC.com. Thank you so much for participating. I'll reiterate the instructions that I gave at the beginning of the webinar really quickly. As we end the webinar here in just a minute, an evaluation will automatically pop up on your screen. If you'll take about 30 seconds to complete that evaluation, we would be grateful. It's a continuing education requirement for us. That information is gathered, it's anonymous, and then it is sent to the CE approvers. So if you'll do that, that'd be great. And then about an hour or so from now, you'll get a separate email from GoToWebinar with a link in that email to take the online test. You must take the online test and pass it in order to receive a certificate. And when you do, the certificate will be automatically downloaded for you. Please feel free to contact us if you have any questions. Thanks again for participating, and we hope to see you again next month.